Thank you everyone for joining. My name is Steve Pardue, one of the managing members here at Elevate Oral Care. Before we start, I wanted to cover a few housekeeping items. For those remaining online past 50 minutes, your CE certificate will be emailed to you within hours of completion of the talk. Please be sure to check your spam folder. You're muted, so don't worry about background noise, and we will have time at the end for questions. So please submit questions through your webinar dashboard, and we'll track those questions through the talk. Over the past 2 years, we've held a series of free live CE webinars on many different prevention topics. Each of these webinars was recorded, and they're available with a free self-instruction CE at the web address you see on your screen, elevateoralcare.com/elevatingcare. Bookmark that page and return often to see what's new. If you have a topic you'd like to see covered, please feel free to suggest it by emailing it to us at info@elevateoralcare.com. For tonight's talk, we're honored to have two experts in glass ionomer. They'll discuss the materials, the uses, and preventive nature of glass ionomers. Our first speaker is Dr. Hien No. He has extensive experience in private practice, research, and education. As an educator, he's published and lectured extensively internationally on dental materials, minimal intervention dentistry, and caryology. He serves on the editorial boards of several dental journals and has been very active as an international speaker and has contributed to numerous major international meetings. In research, he's active in areas of dental materials and caryology and was invited to the University of Queensland as professor and chair of the general dental practice in 2009. In 2012, he joined the University of Kuwait as professor in the Department of General Dentistry, Dental Practice, and director of comprehensive dental care. Then in 2016, he joined the University of Sharjah, United Arab Emirates, as dean of its faculty and dental medicine. And he is now the dean of dental school at the University of Western Australia. Our second speaker, Dr. Doug Young, is a professor emeritus at the University of Pacific, where he is an active and ardent educator in the field of minimally invasive dentistry and caryology. He most recently worked for the Alaska Native Tribal Health Consortium as a specialist in oral health promotion, and he is currently the director of minimally invasive dentistry at CMAR Community Health Centers. He was one of the founding members of Canberra Coalition, Caries Management by Risk Assessment, American Dental Education Association, ADEA, Caryology Section, and the American Academy of Caryology. Dr. Young has served on the ADA Council of Scientific Affairs and is currently a caryology consultant for the ADA. He has presented at congresses and universities around the world and published in numerous peer-reviewed dental journals and textbooks on caries management using minimally invasive dentistry, silver fluoride, and glass ionomer restoratives. Dr. No, I will hand the floor over to you.
Yes, thank you very much, Steve, for the introduction and the invitation. But I also want to thank Doug for allowing me to present first. As you have heard from my CV, I work in many parts of the world, and the concept of minimal intervention dentistry and preventive dentistry is universally true. Wherever I go, it's the same demand, it's the same products that people are not very familiar with when it comes to preventive dentistry. So today, my task is really to look at how can we link a traditionally restorative material like glass ionomer into some of the preventive concept, and maybe revise a little bit of how do we best use glass ionomer in the clinic. Yeah, as G.V. Black said in 1908, in our profession there seemed to be a divorcement of practice to the pathology of dental caries, to the science behind it. So when we're not careful as a clinician, we might end up doing things in a very, very mechanical way. And I give you some illustration of that. On the slide there, on the left-hand side, you saw, just a minute, let me go back a couple of slides. Yeah, on this slide, on the left-hand side, you see that I borrow some slide from an article where the practitioner identified that in between the two premolars there was lesions. He went on and prepared cavity. He then stopped, actually, on slide number 2. He actually stopped at this point in order to show us the justification for cutting in, which is this demineralized area in the enamel. Then he went on and cut 2 symmetrical boxes, which were designed mainly for amalgam. However, in this case, he's going to use glass ionomer cement. So this sort of practice, I can still see that out there, and it makes me really, really worried, because it shows that we don't quite understand how that teeth are very precious, and we need to preserve tooth structure whenever you can. So on the right-hand side, it's not a finished preparation, but I want to illustrate. One of the point that is important to see here is which marginal ridge. If you have a situation where you have 2 adjacent cavity, which marginal ridge do you sacrifice? Because you don't need to sacrifice both of them to gain access. So if you once decided that you're going to sacrifice the marginal ridge on the first molar, you are already can get access to the mesial of the 7th. So you don't need to really cut another box, interproximal box here, in order to restore that. Those seem to be simple concepts. However, it took a long time for our profession to move away from just blindly go in and gain access in a traditional way, and the concept of extension for prevention is still very much there. Well, my professional life started with amalgam. It moved on to hand mixed composite resin, then light cure composite resin, then glass ionomer cement come along. And glass ionomer cement, I would say, has a lot of disadvantages, but it also have a lot of advantages. And my job tonight is really to illustrate to you when it is best to use glass ionomer cement. It's not a substitute for composite resin, but there are situations with only glass ionomer cement would work. And when you choose to use glass ionomer cement, what are the clinical steps that you need to take in order to gain maximum clinical performance from the glass ionomer cement? Glass ionomer cement, as you know, is a powder containing aluminum, strontium, calcium, mixed with a 10% polyacrylic acid. That means that the polyacrylic acid is mixed in water. And that's a characteristic of the material. It is a water-based material. It is an acid base. Once the powder meet with the liquid, ions like aluminum and strontium got leached out of it, and that formed the matrix that helps solidify it. And bear that in mind, that very simple chemistry in mind, because it has clinical implication for you to understand that. If you look at the case above, and this case, a very frail 90 years old man came to see me, and he said, really, he just want to be pain-free. He doesn't want any fancy work to be done. He know he know that he only need palliative care dentistry, something to carry him through for the next 4 or 5 years. We don't know how many years at that point, but it turned out to be 5 years. And he doesn't want extraction. His medical condition will make him frailer. And when you look at this lesion on the central and on the canine, I would look at the depth of it, how far it has gone under the gingiva. Moisture control would be very difficult or unachievable. Acid etch and maintain a dry field would be impossible. So in this case, I would say the material of choice here of all we have must be a glass ionomer cement. So to use glass ionomer cement, it's very important that you don't freehand build it. Somehow they always need to have a matrix. The matrix that you see here is a metal, soft metal matrix, protect the material while it's set, and it actually help you not having to do too much carving and finishing afterward. So we fit that in, and this matrix is actually fitting down to the base of the lesion itself. I burnish it, then I cavity prep that, not with the objective of removing all the caries that left behind, but because if I did that, there would be any teeth left. And secondly, not, you have to remember when we say we leave some caries behind, there's some very important steps that need to be achieved if it's going to be clinically successful. It's a very it demands a lot of attention from us, and toward the end of this presentation I will illustrate that. After that, we put a primer. A primer is the more diluted version of the liquid itself. It's for that, you know, you can use the liquid and dilute it with water to do that, or the manufacturer actually sell the conditioner itself. So the blue liquid there is a conditioner. I wash it off. Then I inject the glass iron cement. One of the problems with using glass iron cement is it's sticky. Its handling characteristic is not ideal like composite. So if you push it in freehand and you try to, it will stick to the instrument, so create a lot of void. Therefore, I always use an injectable glass ionomer cement. One is injected, so there's no bubble air trap at the base of it. I will seal it, burnish it. I will leave it on while I'm doing other things. After 3 minutes, I peel the matrix back, and it's just a question of getting a surgical blade and just scrape off some of the excess around it. That's all that you need to do. I don't use any hand instrumentation again in this case. And glass iron cement have to be protected by a resin coating. So the curing light that you see there is the curing of the coating of the glass iron cement and not the glass iron cement itself. And we're going to go through some of these characteristics a little bit later on. Well, glass iron cement is an acid-base reaction. That means when you first mix it, it's acidic material. And therefore, what sort of bonding happened between the glass iron cement and the tooth is quite different from resin bonding, where you actually have a intertwine of the resin into the hybrid zone and all of that to form the seal. The glass iron cement form a chemical hybrid zone, which I will show to you now. So sorry, always technical issues. My primary work for my PhD was glass iron cement interface. And on the left-hand side, when you look at this SEM, you see this SEM of the interface between glass iron cement and the enamel. And I want to point it out to you that the interface itself looked a little bit like a mountain range. It has a broad base, and then it has a sharp ledge that go across it. In order to understand the implication of this, I'm going to use a diagram next door in order to explain to you how we get to achieve this picture. The green is a glass iron cement, and we restore the tooth of glass iron cement. I section it, I polish it. Then I just gently apply phosphoric acid for 1 second. And the purpose of that is just to remove the debris, because when you polish things, there's a lot of smear layer on the surface, and that would make it harder for us to visualize that that interface. After I wash away the acid edge, now you can see that mountain range is formed. The mountain range is formed. It infers that the acid has attacked the tooth. The acid have attacked the glass iron cement, but the interface is a proud interface. It's more acid resistant than enamel, or more acid resistant than the tooth. That is a hybrid material. Inside this mountain, it contains element of glass iron cement and tooth mixed together, and therefore it becomes resistant. To make it easier to understand, If I now mix a glass iron cement, inside that you have calcium, phosphate, aluminum, and it's acidic, so all this blue ball represent those chemicals. The tooth itself is contain calcium, phosphate, which are the red square. You mix the two together, the acidity of the GIC at that point make it act as a self-etching system. And so calcium and phosphate will come across into the glass iron cement, strontium and aluminum go across onto the tooth, and the pH neutralizes the whole thing, settle down where they are in order to create that chemically hybrid between glass iron cement and tooth, and that's the chemical hybridization of the interface. I show you evidence of it. In this case, where after we prepared the tooth, section it, this dark line is a crack, which is an artifact. As you can see, glass iron cement is at the top, the tooth is down here. You can see the cohesive failure fracture of the glass iron cement. It means even under this stress, vacuum stress, glass iron cement still stick onto the tooth. So the failure line is within the glass iron cement itself. Now the color distribution is understood like this. If it's yellow, white, a lot of strontium. Blue, black means there's no strontium. You have strontium in the glass iron cement. That's why you see all the glass particles all bright in yellow. But then in the tooth, there's no glass strontium. That's why it's black. However, if you look at it carefully, you can see a band of blue here that represents strontium that have migrated from the glass iron cement over to the tooth. Now let's look at the reverse. Now here's the reverse. If it's a calcium, it's yellow. In the glass iron cement, there's no calcium, so it's black. Here's a tooth. You can see on the glass iron cement side, there's a band of blue that represents the calcium that had migrated from the tooth over to the glass iron cement. So when you look at the mountain range will start, the base of it start from here to here. It incorporated both material in it. Glass iron cement is not only a restorative material, and I have a declaration to make here. I'm the inventor of this material. This was done 30 years ago. It's called Fuji 7. In the US, I believe it's called Fuji Triage. So when you look at the glass iron cement component, you have the powder, you have the acidic liquid, you have the conditioner, the cleaning of the tooth surface that I told you before. And then on top of that, it doesn't show here, but other glass iron cement would also have a bottle of coat in order to provide the protection. This Fuji 7 was designed to be pink for identification, high fluoride release, high water tolerant, and it's thin material, so it can be used in order to prevent to provide some prevent from caries, for lesion from forming in the area where traditionally we can't handle. When you use glass iron cement, the most important thing is this. After mixing, you have to tap the case, because otherwise for storage it gets settled. So when you tap it, it get mixed easier. Mix an amalgamator for 10 seconds. And this is one key feature I want you to show you that you must have on your glass iron cement. If you don't see this, then it was not mixed properly, or you should not use it and should really get another batch. When I first squirt out this glass iron cement, can you see the shininess on that surface? That gloss is essential. And as the glass iron cement set, after about 40 seconds, you can see the gloss disappearing. Once that gloss disappeared, then the glass iron cement have lost its ability to chemically bond to the tooth. The ability to form that mountain range is only there when the glossiness of the mix is still important. Now, for you to actually choose a glass iron cement, it's much simpler now. In the early days, we have calcium-based glass ionomer cement. Nowadays, most or 90% of glass ionomer cement are strontium-based. This is very critical because a calcium-based glass iron cement don't necessarily have the radio opacity that allow you to detect a restoration in place. Strontium replaces calcium, and strontium also help in the remineralization and prevention process. So you have to make sure that you ask your rep, does my glass iron cement contain strontium or not? That's one key. Now, when you first place glass iron cement and you allow saliva to touch that glass iron cement, it's been reported that after 40 days exposure to that saliva, you increase the hardness by 40%. This is very important to remember. You have to keep it dry when you place it, but after placement, after you finish it, you put that coating to provide some further protection. But after that, when all that wear off, it starts exposed to saliva, it becomes harder. To show you this study where the vertical line is the hardness and the number of time exposure is down at the bottom there. They place a glass iron cement, then expose immediately to water after setting, and they find that the hardness will increase after 40 days. Then it matured enough, it reached its potential to plateau out. Now, if you put a glass ionomer cement and no protection, immediately you put into saliva. This is a comparison between the blue line and the orange line. You will see the same phenomenon, except at this point, the surface hardness after 80 days is almost double. Now they study it and they look at what if we put a coating, place glass iron set, put a coating on, then what happens? Once you put the coating on, the hardness is higher than no coating, but after 80 days, nothing changed. After you expose to saliva, nothing changed. Now they do the final test. They put the coating, like I show you in the clinical case. They wait for 80 days, and then the coating is worn off by mechanical wear and all that. Saliva start acting on the glass iron cement. Now the surface hardness of that is much higher than it can be achieved by anything else. So the application of this is this. While you're placing, you have to not freehand build. It got to have a matrix formation to protect it during setting. Right after setting, you don't allow water contamination, you put a coating on it. Once after the coating is wear off, you don't have to do anything. It will wear off by itself in the mouth. You can believe that with a healthy saliva, that glass iron cement become even harder. So I will tackle that a little bit later on. I will step back now and talk of a new concept on how to use Fuji Triage Pink. This concept was designed when I was looking at teeth, and I see that when the tooth is forming and growing under the operculum, the eruption time of the first molar and second molar, it can be close to 12 months, 18 months. During that time, plaque and debris will collect under the operculum. So these tooth potentially, and these are my two children where I just introduced them here to you, Lauren and Nathan, because they actually have the prototype in them, and now they are 26, 24, and the prototype is acting as a fissure sealant in their case. So we don't do anything, plaque accumulating there. When you look at an extracted tooth, you can see the whole surface under the operculum has been demineralized. And that's common sense. I mean, it's not cannot be cleaned, not disturbed. It will demineralize that. So when you have a demineralization on the entire surface, it's very difficult to remineralize that later on. So we propose that we use Fuji triage, and we push the triage under the operculum to provide a temporary protection during the eruption time. That's why we call this a pre-fissure sealant procedure. After the tooth is fully erupted, you can choose to leave it there as a fissure sealant, or you know, if it's have been washed away, then you can actually look at and redo the fissure sealant using other material. Here's a video to illustrate what we do with this. That's our operculum. Moisture control is by rubber dam only. There's nothing else we can do. We clean it with conditioner under the operculum using a micro brush. You wash that off. Bleeding can be an issue here, so you have to be careful, be gentle with it. Then the nozzle of the Fuji triage inserted under the operculum. We don't have to fill in the space. We just want to form a very thin film on the surface and entire surface, even the exposed one. Fuji triage setting can go faster if you put a curing light on it. It's not that because it has resin in it, but the blue light absorb the color pink absorb the blue light, heat up the material, so therefore the chemical reaction happen faster. So I repeat, there's no resin in it. So if you use a Fuji triage white, you cannot use the light. The light doesn't help the setting reaction of it. Only Fuji 7 pink. I have about 7 minutes left now, so I'm going to move to the next concept. Is how can we use glass ionomer cement when we're talking about restoring very large lesion like the one that you see on the screen on the tooth number 7. With this, it's very important that you do your diagnosis. You have to do your pulpal testing, endo testing, and the diagnosis is endo is this is reversible pulpitis. I'm not talking about irreversible pulpitis here. The question has always been, how much caries can we leave behind? So I want to tackle that. And I want to really bring you the good news that there are now consensus on how much caries dentin can be removed. Many studies have been done, and finally, after all this year, we have consensus. With Fujiyama and Masler, what they say was this caries dentin is divided into 2 zones, the infected zone and the affected zone. And the principle behind all this is you remove the infected zone, you leave the affected zone for remineralization. I tell you, that concept is good in theory. However, in the clinic, it's almost impossible to determine when you have finished removing the infected zone. And that led to a lot of clinicians over removing because they're not sure whether they have removed the infected zone or not. Moving forward, I wanted to not talk about infected, affected anymore. I want to basically say you do your case selection like shown on the screen is reversible pulpitis. You're not talking about irreversible pulpitis. I would go in and I would use a round burr running very slowly, a number 3 round burr, to remove as much of the loose debris I can without having any risk of pulp exposure. I use that burr in order to create this sound, very sound dentin margin and denture and enamel. What I leave behind here is not important as long as I can achieve this band of sound dentin and sound enamel, because this whole principle works when you can actually seal the cavity. Once you seal the cavity, the bacteria that left behind cannot survive in that altered environment. And this seal, if it's in enamel, I trust the resin seal. But once you go down to the gingival level where moisture control can be a little bit tricky, I would rely on a glass ionomer cement base to provide that seal. So once for this, all I do is get a spoon excavator. I'm not really trying to dig into it. I scrape off whatever loose. I would remove that. Then I will wash this conditioner off. I will use the Fuji Triage as a liner because we have done some study to show that it actually put much more strontium and fluoride into that soft dentine behind. Because here I don't have enamel, and because the lesion is too deep, cavity is too deep, I cannot guarantee that I have full polymerization of the resin there. I put a glass iron cement base. I don't build it up and cut back. I build it up to where it is. I use a self-etching system, and then I restore it with composite, and this is what we call in total a sandwich restoration. So this is so important. I want to once again summarize this for you. This lesion is different because it's entirely in margin, can be in enamel. We have that border, clean border, by using a reduced handpiece. Number two, number three, round burr to go right around there under the enamel, right the entire cavity. We only remove this by hand instrumentation. Then in this case, I would restore it with resin, and I don't need the glass iron cement base because there's enamel right down that gingival level. There's rubber dam. I can control moisture in this case reliably. The evidence that we have in doing this, encourage us in doing this, is a project, a clinical trial project that I did in Fiji. We actually went to Fiji and selected 60 teeth that have moderate sized lesion, but no sign of irreversible pulpitis. We basically just have a clean enamel margin. They're all class 1. We didn't even use a burr here. We clean nice and tight, make sure that you actually have a clean border. We put glass iron cement in, and this is one of those teeth. When they got extracted, they were sent to me for processing. And our plan was that out of the 60 teeth, we're going to extract 20 at 1 month, 20 at 3 months, 20 at 6 months, so that we can measure the level of mineralization. So here it's a preparation to look at the analysis. You know, after the first lot, we were able to collect close to 20 teeth in 1 month. Then bad news came through. The bad news came through from Fiji, where people say to me, we could not collect many of 2 months and even 6 months at all, because the parents said the tooth doesn't hurt anymore, so there's no need to extract that anymore. But I was saying, well, but that's part of my study. You ruined my whole study. But thinking back now, I should be really happy the fact that I saved 40 of those. Maybe I could have saved all 60 of them because symptomatically they disappear and patients don't want to withdraw from the trial. So when we do analysis, so the analysis was done, as you can see, from here to here. I want to build a map of how much calcium, and in sound dentine, calcium is here. In the lesion, the calcium dropped down to 10%. How much phosphorus is there? And then I look how much strontium is there. There's no strontium in the tooth, remember? So any strontium here have to come from the glass ionomer cement. So the strontium now has come in at the peak here, and it follow until sound dentine. And because it stopped here, is because There's no more missing calcium for it to replace. Fluoride followed the same pattern and penetrated into here. So therefore, you infuse strontium and fluoride into the softened dentin. It's not that you just leave that softened dentin untreated. So by default, by doing it this way, and there's many different ways of addressing this, I feel that we chemically treat that as well. So how long should we leave it on? We did a study looking between how much strontium and fluoride get into the lesion. Fuji 9, Fuji 7, Fuji Bond, Fuji 7 triage is do a little bit better. But then if we wait for 42 days, so the infusion of strontium and fluoride doesn't happen instantaneously. With time, we more than triple what Fuji 9 can put into those lesions in both fluoride and strontium. I got some, I think, how much time have I got, Steve? Because I got myself lost track of time now. Have I run out of time?
If you can finish up, that would be great, yes.
Okay, right. So sorry, I got a timer here and accidentally stopped it. So I thought I still have 7 minutes. So in placing glass ionomer cement, the other important things is once you place glass ionomer cement, do not acid etch that glass ionomer cement, because if you acid etch it, you will see that in this case here, all the matrix is being dissolved away here and the glass are loose. But when I use a self-etching system adhesive, you can see that the glass particles are embedded strongly in the matrix. So therefore, that is very important. And one last step here, I just want to share with you is avoid having this air trap at the base of it. And the only way you can do that is by using a capsulated version of the material. If you don't do that, then this air void will definitely form under the lesion. My apologies for running over time, and I thank you very much for your attention. I'll hand over to you, Steve.
Hello, everybody, and thank you for the opportunity to share with you a little bit about what I know about ensuring clinical success with Glass Ionomer Restorative and Sealants. What a wonderful presentation we just heard from Dr. Hien No. I consider Hien a great friend because he taught me everything about Glass Ionomer younger in my career, and I wanted to thank him very much for taking me under his wings. Hien, I consider you the father of the modern glass ionomer. Your work has been pivotal. So thank you very much. Let me continue from where Hien left off and talk to you about some clinical issues. The important thing from the first slide is my email. It's dyoung@pacific.edu. Happy to answer any of your questions. Disclosures today. Of course, I don't represent the ADA in any fashion, but I did have the pleasure of working on the council 2012 to 16 and remain a cariology consultant for them. Financial relationships with industry, speaking honorariums from Elevate, GC America, and Oral Biotech. Today's webinar is sponsored by Elevate Oral Care, and I also own some minor stock in Oral Biotech. Today's objectives are pretty simple. I want to point out the chemical advantages of glass ionomer restoratives and sealants because they're unique. No other material has that. Number two, I want to state the level of evidence. We don't have a lot of time to talk about each paper, but at least I want to show you the reference so that you could look it up later on your own. And lastly, I want to make sure we go over proper placement techniques that have been working for me for both restoratives and sealants. Now, one of my pet peeves is treating disease. You've heard of Cambra. So caries management by risk assessment. So let's assume we've already done a caries risk assessment. We developed a caries risk management plan using motivational interviewing and shared decision-making with your patients. Because if we don't understand what they value, how can we have them change their behaviors? Because we need them to do behavioral change to implement the strategies that we recommend to combat the disease, which should include biofilm modification, a pH strategy, halting demineralization, and enhancing remineralization. So let's jump right in and talk about glass ionomer sealants. The level of evidence for glass ionomer sealants are quite high. Systematic review, meta-analysis, and above that, critical summaries and the tip-top ADA evidence-based guidelines. In 2016, the evidence-based guideline for sealants came out with two significant findings. One, there's not enough evidence to judge which material is best. In other words, they're basically equivalent. You're free to use resin or glass ionomer. Number two, you can seal over non-cavitated lesions. What? That's the first time they said you could seal over decay, as long as it's not cavitated, fully cavitated. For that, we need to understand the importance of cavitation. So my famous slide here showing the size of the bacteria is the person standing on the beach. The enamel rods and prisms are the sands in the beach, and the spaces between the grains of sand is the enamel diffusion channels. And clearly, the bacteria are too big to fit through the diffusion channels. Yet, if you pour a pitcher of lemonade acid on the sand, those molecules are small enough to soak down into the subsurface. So unless the tooth is fully cavitated to the dentin, the bacteria cannot get in, and it should trigger more conservative treatment, such as remineralization. The ADA, jumped ahead. The ADA came out with the American Dental Association Caries Classification System in 2015. And I was lucky enough to be on the council at that time. We came up with this chart, and it basically says three different things. On the occlusal surface, you can seal, according to the ADA evidence-based guideline, you can seal non-cavitated lesions. So green column, yellow column, orange column can all be sealed with glass ionomer sealants. Only the red column on the right, where you can see fully cavitated lesions with your naked eye, should trigger surgical restorations. The second row of pictures are the facial and lingual. Same thing there. Green, yellow, orange column can all be treated with what Ian already described as surface protection, or simply remineralization using Cambra, or 3, silver diamine fluoride. The bottom row is where it's problematic, because people read radiographs thinking they're looking at cavitation, when in fact it's just picking up mineral density, usually meaning the extent of demineralization. So the ADA Council of Scientific Affairs came out with a paper saying that it is unlikely to have infected dentin is another way to say it's unlikely to be fully cavitated, because if there's any remaining enamel, the bacteria can't get in the dentin. So my pet peeve is to refrain from cutting the D1 lesion that just penetrates the DEJ. Getting back to the topic of occlusal sealants, a lot of people have a myth that sealants or glass ionomer cannot be used on a chewing surface because it won't hold up. A lot of people also think it's soluble. Well, I'm going to show you a few pictures. This one showing you a 3-year-old low viscosity glass ionomer sealant that A, did not wash away, B, did not stain at the margins, and C, did not fail under occlusal forces. Graham Mount in his textbook showed 8-year-old and 12-year-old sealants with absolutely no sign of those myths. These look like the day he placed them. Okay, what did we learn about sealants in the age of COVID, where we don't want to have a lot of aerosol? Well, over the years, if you just mark the occlusion with articulating paper and avoid putting any glass ionomer there, you won't have to adjust the occlusion afterwards. Make sure you mark the occlusion in all excursions. I like to recommend a suction bite block device because it retracts the cheek and the tongue. I like to work in quadrants if you use that bite block. And when you get good, you can actually do half of the mouth at a time. One capsule for the right side, upper 4 teeth, lower 4 teeth, that's 8 teeth. Flip the bite block over, do the other half of the mouth, another 8 teeth, 16 teeth, 2 capsules, you do the math in less than 5 minutes. To clean the surface is very important, especially the pits and fissures. My favorite is defocused air abrasion, followed by a slurry of pumice on low speed. And during the age of COVID, a lot of us became creative, and a lot of people were using a slurry of pumice mixed with a little acid etch. Never ever use acid etch on dentin because it removes mineral, leaves collagen, and glass ionomer has no chemistry, no chemical bond to collagen. So that trick is only when there's enamel, especially on the pits and fissures. By using that slurry abrasion on a cotton ball, we're hoping to remove some of the pellicle, biofilm, and debris out of the fissure. Again, not a lot of research on that. It's just a stab in the dark during COVID. Always remember to use the polyacrylic acid as per manufacturer's instructions. It's called tooth or cavity conditioner, and you put it on for 10 seconds, rinse it for 10 seconds, and blot dry, leaving a thin layer of moisture. I like to use a cotton tip applicator saturated in water and then rolled in a 2x2 to remove all the excess water, to move or pat down the excess glass ionomer, and then so it won't stick to the cotton applicator. If you don't use that, you have to use, and you're trying to use an instrument, you have to lubricate the instrument with unfilled resin or it'll get stuck on your instrument. And of course, same with the lubricated finger. I found that low viscosity glass ionomer is much easier for beginners because it's the same viscosity as resin-based sealants. It flows better. You can move it with a microbrush or a explorer, and I think it's a little faster. If you use high viscosity using the finger push technique, you create a little bit more of a mess and you have to clean it up at the right time or you glue the teeth together. So that has a steeper learning curve. Okay, back to Hien, your famous work on electron probe microanalysis and showing us that glass ionomer bonded to enamel has an impervious chemically fused layer that you see in yellow, and it won't dissolve under acid attack. So thank you for showing us that. Again, this is a slide. He bonded glass ionomer to enamel, sectioned it, removed the smear layer with phosphoric acid, which dissolved the enamel and the glass ionomer, but not the chemically fused layer. This layer we anticipate is fluorolapatite, and that's why it didn't dissolve. And unless you physically remove the restoration with the burr, how on earth is the chemically fused layer going to be dissolved? So it's there forever. And one of the few unique things that glass ionomer has is the ability to do remineralization. Resin does not have that capability to this effect. Does it happen on dentin as well as enamel? Yes. Thank you, Graham Milicic, for your article in the Journal of Microscopy showing that it does, in fact, happen on dentin as well. Now, what do we get from that? In summary, glass ionomer restoratives are unique. They are better at preventing lesions because of the internal remineralization and unique chemically fused layer to the tooth. In fact, studies show that chemically fused layer is almost like welding 2 pieces of steel together, because when you subject it to forces, it breaks in the restorative material before the bond to the tooth will break. And I will demonstrate that for you later with the hammer video. Also, glass ionomer is unique at releasing fluoride and recharging with fluoride from other topical sources such as toothpaste. This is a skipped one. This is a slide showing that there is secondary maturation of glass ionomer when you subject it to saliva rather than water. In fact, if you wait 2 years, it becomes harder and harder because of the minerals and the metallic ions in the saliva get imparted on the surface. And the surface actually becomes as hard as enamel after 2 years. Now, I want you to watch this video.
Again, the strength of glass ionomer in an unscientific test. What we did is a large crown type preparation and made a crown glass ionomer. And we stored it in saliva for 2 weeks. And now we're trying to break it.
So there's no glass ionomer on the surface. It's totally going to be a glass ionomer crown. And I soaked it in saliva for only 2 weeks, which is not a great amount of time. And then I tapped it on the counter to simulate chewing and didn't get any breakage. So now I'm slamming it at the counter. This is Dystone, not plaster.
Still in the tooth.
And I'm trying to get the glass ionomer to separate from the tooth.
The stone broke.
I marked the margins in pencil.
You want to get a close up?
You can see the pencil line.
All the margins are intact. There's a few chips, granted.
That's a joke. We're Oakland folks.
Okay, look, we got the tooth broke in half. But I want you to notice I was hitting the glass ionomer straight up on the occlusal where there's no enamel, and it caused the whole tooth to split in half. But the glass ionomer is still in the tooth.
So the chemical bond at the tooth interface is like welding 2 pieces of steel. It won't break there. So I hit the glass ionomer. Let's see what happens when I hit the enamel. In this case, I'm going to do an MOD preparation and try to hit the cusp tips of the enamel to try to get it to separate from the glass ionomer. And again, we mark the margins in pencil for you. And let's see what happens.
That's about as hard as I would hit a small nail. The bottom of the root is shattering. And there we go. Again, we have the tooth splitting in half, but the glass ionomer is still in the tooth.
So if you believe that it doesn't hold up to occlusal forces, I don't think anybody chews as hard as a hammer. He uncovered this about selective caries removal and cleaning the perimeter of the lesion by 2 millimeters. And so I'm going to just show you the level of evidence for that is quite high as well. Critical summary published in JADA by Van Thompson showed that there is substantial, not a little bit, substantial evidence that leaving all vestiges of infected dentin approaching the pulp is not required for caries management. I want to show, one more thing. If you run out of enamel, let's say you're on the root, only go 1 millimeter into the dentin on the axial wall to prevent from hitting to the pulp. This is a slide from Mike Nelson. He's a master at doing these large lesions. And the only criticism I could have told him is don't cut the dovetail because there was no radiographic evidence of a cavitation on the distal. This is a white spot lesion. You could have strengthened the tooth by leaving this enamel, holding the buccal and lingual cusp together. In the upper left picture, upper left, I would just take a number 8 round burr and undermine enamel with that and clean it using the 2 millimeter rule. Undermining enamel with glass ionomer is a good thing, not so with resin and amalgam, but think of that chemically fused layer, that welded steel underneath that glass ionomer is going to resupport it. However, when you take a radiograph, you're always going to see the partial caries removal under the radiograph as a radiolucency. So if you're a dentist looking at other people's work, inspect the margin. If the margin is intact, it's either non-radiopaque dental material or it is selective caries removal. No need to replace it. Only if there's recurrent decay at the margin or leakage that you would replace the restoration. Let's go through the 10 steps for success, because I want you to be that guy in this picture. Dr. Hederi on the left is a resident at our AEGD program, and her wonderful work is represented on the right. Half of the mouth was done with composite, half with glass ionomer, and they both are aesthetic. I'm going to tell you which is which a little bit later. So here are the 10 steps. The first one is the most important because nobody does it. Clean the entire tooth. You want to remove the pellicle and the biofilm because glass ionomer has no chemical bond to that. You need mineral. So you want to make sure you use it. I like defocused air abrasion or pumice, gray pumice with slow speed. Again, if you can't use rotary hand instrumentation because of aerosol, you can get creative with pumice and a cotton ball and scrub it. Clean the perimeter of the lesion as Ian showed you, either with your technique of choice, rotary handpiece, air abrasion, hand instrumentation such as hand drills and spoons. Third step, condition with polyacrylic acid for 10 seconds, removing the smear layer and activating the surface. Rinse with water for 10 seconds, blot dry, leaving a shiny, thin layer of water. Then place your matrix and wedge if you need it. Why clean it first? Because if you don't, and glass ionomer gets outside your band because it's more liquid than composite, it won't be chemically bonded. So make sure you clean the entire tooth, then place your matrix. If there's any contamination, simply wash it out with water, blot dry, and then put your glass ionomer in. You do so by mixing in the triturator for 10 seconds and apply it immediately from the bottom up, caulking from the bottom and withdrawing the tip so that you don't get any voids. So 10 seconds of mixing followed by 10 seconds to run over and get it into the tooth, and 10 more seconds to shape it and remove any excess. Total time from start of mix, I shoot for 30 seconds. Why? Because if you train yourself to get it in 30 seconds, it'll never A, set up on you, and B, you will never break the initial cross-linking as the glass ionomer is setting. Step number 9, protect from water loss or water gain. There's many ways to do it, but one way is to simply watch it, and when it starts to evaporate at the surface because it's turning dull, you can simply wet it again, water or saliva. Or you can cover it with something like unfilled resin, Vaseline, cocoa butter, you have it. And then the last step is don't disturb it until it's fully set. 2.5 to 3.5 minutes, then you could finish and polish. I like 2.5 because it's a little bit softer and you could polish it using the abrasive composite abrasives. Again, here's the answer to the key. The patient's right side was glass ionomer, the patient's left side was composite, and it's perfectly aesthetic, breaking the myth that glass ionomer is not aesthetic. Hats off to Dr. Hederi for doing proper perimeter cleaning using selective caries removal. The glass ionomer completely covered up the black or the arrested area, and which proves you can also cover up silver diamine fluoride. Posterior restorations using glass ionomer also has pretty high levels of evidence at meta-analysis. Here's one showing that glass ionomer was equivalent to the gold standard they compared it to, which was amalgam. Another study, systematic review, showing the same conclusion. And finally, a meta-analysis showing that glass ionomer was better if you count prevention at the margins. Okay, so let's summarize. If you can clean the margin, all you need to do is place a glass ionomer restoration. You bill it the same billing code as composite. If you can't place a restoration, you can certainly place silver diamine fluoride and arrest it using CDT code 1354. You don't have to restore it as long as you place glass ionomer twice a year for every year until it's restored or lost by natural causes or extracted. A third choice is why not arrest the lesion first so you can verify it's arrested, followed by a washout period where the free silver ions are allowed to go away, and then restore it last. And at that point, you can restore it with anything you want. And have no fear, it will not stain your restoration dark. Now, that's called two-step smart. Arrest first, restore later. Now, what if you have to or forced to place silver diamine fluoride and glass ionomer on the same day? We call that same day smart. And we're going to go over that now. SMART, by the way, stands for, you know what ART is, atraumatic restorative treatment. Well, SMART just simply means modified to include rotary instrumentation, whether it be rotary handpiece or rotary hand drills, and two, the application of silver, in this case, silver diamine fluoride. Here's some pictures showing 2-day smart or two-step smart, showing arrest of the Pitt and Fisher lesion first, and then covering it up with a picture on the top using high viscosity glass ionomer, picture on the bottom right showing low viscosity glass ionomer, showing that it will cover up the black. This is a study showing that showing that the bond strength of glass ionomer is unaffected by silver diamine fluoride. What I'm going to go over now is same day smart. This is the lesion pre-op. It's wet. So the first step in applying silver diamine fluoride is dry the lesion, because a dry sponge will soak up more material than a wet sponge. So dry, apply the silver diamine fluoride for at least 1 minute when possible. More is better if you have a cooperative patient, but never use a cord because it will tattoo the gum, as you see here. And so this will go away in 1 to 2 days, or at least in a week, on soft tissue in the mouth. And so have no fear, it won't cause any harm, but it just looks ugly. Hats off to this person, Dr. Vu Li, for doing proper perimeter cleaning using selective caries removal and leaving the deeper areas alone on a vital tooth. Okay, we're pretty much done. I wanted to shout out for the SMART textbook published by Stephen Duffin and team. It's available on Amazon, and also it's available in a PDF format online now at smartoralhealth.com, and it's free online for the PDF version. It is now time for questions and answers and discussion with Hian and myself, and I look forward to that. Last slide is just to have no fear. You will get your CE certificate within a few hours, I hope. If not, it'll come shortly after. And the recording will be available at www.elevateoralcare.com/elevatingcare. And so thank you very much. I know I went quickly, but that's the best I could do in 25 minutes. So I'm going to turn it back to our moderator, and I look forward to sharing our time together verbally in your questions and answers session. Thank you very much.
Thank you very much, Dr. Young and Dr. No. We appreciate the presentations very much. And thank you all for joining us today. We will have just a couple of quick questions here. We are out of time, so I'll keep the questions very short. But the first question that came in, I'd like to offer this to Dr. No. It's a question about, can you use 37% phosphoric acid for 5 seconds instead of polyacrylic acid?
I would not recommend using phosphoric acid because with the dentin conditioner, the acid is the same acid in the material itself. So even if when you wash it, you actually prime the glass ionomer cement for that already, where the phosphoric acid could remove all the minerals which then required for bonding.
Okay, very good. I appreciate that.
I'm sorry, I want to add, I do aware that there are people who recommend you to use phosphoric acid, but that in their mind is for simplicity. It doesn't lead to a better bond.
Okay. Next question I'll give to you as well, Dr. No. It's about the teeth erupting, and after they erupt, the enamel continues to harden from minerals and saliva. By placing triage on the tooth early under an operculum, do we inhibit the enamel from fully developing?
No, you remember the thickness of the Fuji triage is very thin, and eventually it will wash off. It's to allow for maturation of that enamel. But I think you need to prioritize protection against demineralization under the operculum. We have seen teeth that as soon as they appear under the operculum, there's already a cavity there. Just very important to try to step in earlier.
Okay, excellent. Dr. Young, I'll give this question to you. Do you get the same results with resin modified glass ionomer as you do with glass ionomer?
My pediatric colleagues use resin modified glass ionomer all the time because they need to have a command set with uncooperative children. I mostly work in adults, so I don't usually have the need for a command set. So I pretty much use conventional glass ionomer most of the time, to be quite honest with you, because I find the light curing takes 40 seconds. In theory, 20% resin may block some diffusion theoretically. So it's just personal preference. I think resin modified is just fine. People are having great success with it. So I have no problem with people using it.
Okay, excellent, thank you. The last question I'll throw up to either of you. After placing glass ionomer restoration, is it acceptable to immediately apply the unfilled resin and light cure to prevent water loss and or contamination?
No, that is acceptable. That is what we use as a coating.
Okay, thank you. And Dr., anything to add, Dr.?
Yeah, I just wouldn't light cure it if you use unfilled resin to keep evaporation from occurring, because again, you're going to be finishing and polishing that down and removing that that unfilled resin anyway. Again, I simply would just wet it with saliva or with water, but that's up to you, because if you work in quadrants, sometimes you need to coat it.
And can I just step in there? I totally agree with what Doug said, but there's one more point. Once you finish the restoration, you should place a resin coating for and light cured, because the data that I show you show that if you do that after 80 days, when that resin coating is gone, saliva would improve the physical protein much higher than in any other strategy that we have. So as a last step before the patient leave, once it finished, then I would put on a more protection there.
Excellent. Thank you very much for the answers. And thank you both again for your presentations. We'll go ahead and close out the presentation here. To our guests, your CE certificate will be mailed automatically within about 2 hours. Make sure to check your spam folder, and be sure to follow us on social media for links to new free CE events. The link you see on screen right now will give you access to our archived webinars, including our panel discussion today, which should be accessible by the end of the week. Please share this link with your staff and your colleagues. And finally, on our Elevate Oral Care website, you'll find buttons to request an informative CE eligible staff meeting. Education on the latest evidence in oral health prevention is what we do. Our team is eager to help your offices expand preventive programs. So thank you, stay safe, and have a great week.